I think it's very important for our audience just to see what's happening in the field of surgical audit. So I'd like to invite Barry Beiles to present on behalf of the Australian and New Zealand surgical mortality audits. And I think, Barry, you're going to mention something about vascular surgery as well. Thank you.
Thank you very much, and I'd like to thank the organisers for inviting me to speak. Now, fortunately, surgical audit is blessed because we have very hard outcomes as opposed to soft outcomes to measure, and there's no harder outcome than mortality. And I'd just like to start with the audits of surgical mortality. And the ANZ audit of surgical mortality is a binational network of regional audits under the auspices of the Royal Australasian College of Surgeons. It's funded by state and territory governments and classified as a quality assurance activity under the Commonwealth Qualified Privilege Scheme. And the latter is really the most stringent confidentiality guarantee for participants, because it's punishable by a 2-year custodial sentence and a substantial fine if the identity of the participating surgeon is divulged. Now, the origins of this activity start with the Scottish audit of surgical mortality in '94. This was taken up progressively by different states and ended up in Victoria in 2007. And I'll be confining my initial comments to just the Victorian audit of surgical mortality. The structure is really that we're sandwiched between the college and the Victorian Department of Health, and we're answerable basically to David Waters, our first speaker, and we submit our reports to the Victorian Surgeon and Victorian hospitals. So it is a quality assurance project, and it highlights system and process errors associated with surgical mortality, and it encompasses all deaths in hospital after a surgical procedure or under the care of a surgeon. And the beauty of this system is that it's totally independent. It's a peer review of surgeons by other surgeons without the assessors knowing the identity or the hospital at which the patient was treated. It's purely an educational tool which differs from the vascular audit I will discuss later, and it has been made compulsory for CPD requirements from 2010, which is a very admirable initiative by the college. Because, just my little barrow I like to push, I think there's a sizable percentage of surgeons who do not want to be audited, and I think one does need a stick for this exercise. Now, the process of the audit of surgical mortality is that the hospitals submit notification of death. Surgeons can also, but it's basically a hospital-driven initiative, and all hospitals sign up to the process. The treating surgeon is then identified by the hospital, and our office contacts them, and they have to complete a case record form, and it's then submitted to an anonymous first-line assessment by another surgeon in the same specialty at a different hospital. Based on the form filled in by the surgeon, the first-line assessor will then decide whether this needs a case note review, a more detailed, in-depth review or not. If not, then we provide the feedback from the first assessor to the treating surgeon, and we close the case. If the first-line assessor is concerned, then he gets new batteries for the laser printer. There's an anonymous second-line assessment using de-identified case notes, and about 10% of the cases actually undergo the second-line assessment. And then the feedback is again given to the treating surgeon, and audit of the case is closed. If there are any perceived areas of concern or adverse events, it's reported to the Victorian Surgical Consultative Council, which assesses mainly morbidity, and is a separate body with which we're closely associated. And we submit annual reports to hospitals, the VSCC fellows, and the Department of Health. Now, as a result of the compulsory process of CPD participation. We have currently 91% of surgeons from the college that participate. And we also, for the past year, have had the gynecologists join the process nationally. And in Victoria, we have 55% currently participating. This will increase with time. I'm pleased to report that hospital participation has steadily increased, and last year we attained a long-standing goal of 100% participation both in private and public hospitals. We look at a number of things in this process, and risk management issues is a major focus. The first one of which is DVT prophylaxis, and surgeons reported use of this in 80% of surgical deaths that were reported to us. Remember, this is only surgical deaths that we analyse. The assessors, however, had a look at the appropriateness of the DVT prophylaxis and found that only in 2.5% would the patient have benefited from DVT prophylaxis that was not administered. The next risk management issue is ICU or HDU critical care utilisation. This has steadily increased with time, and we still have some outstanding cases from last year. About 35% still have to work through the system because there is a delay in processing these cases. So I presume that this might show the continuation of the trend of increased use of CCU. And the third risk management issue is fluid balance. And in well over 80%, the surgeon did not feel there was a fluid balance issue, but the assessors, for some reason, found that this was not an issue in only about 65% of patients who died. Now, we also assess the role of the consultant. This is all from the feedback in the forms that the surgeons sent back to us. And it's remained fairly steady. The brown bar is the surgeon operating, and that's been about constant, about 65%. But consultant participation at other levels, under the decision to operate, assisting, or present in theatre, is at about 85%. Unplanned return occurs in about 15% of patients who die. And obviously this is associated with a complication, and it's good to see that there's been a trend upwards in the consultant operating in this category of our patients. Now, after the risk management issues, we also look at clinical management issues as a whole, and we divide them into three. An area for consideration is where the clinician believes an area of care could have been improved. Area of concern is where the clinician believes that areas of care should have been better, and an adverse event is, as we're all familiar, leading to significantly serious complications or death. If we look at the just under 4,000 cases in Victoria, as far as clinical management issues identified by assessors, we can see that only about 15% really fall into the adverse event or areas of concern. Now, if we look at the comparison of the treating surgeon versus the first-line assessor, we can see there's a significant higher percentage of first-line assessors that have identified these clinical management issues compared to the treating surgeon, which validates really the whole process of audit and this exercise. If we look at the second-line assessors, and as only 680 patients who died underwent a second-line assessment, this is even more striking, the difference. This is when the second-line assessor goes through the case notes of the patient involved. If we look at clinical management issues over time, that's since the VASM process has been in operation, you can see that this has diminished steadily in each audit period. If we look at the treatment status, about 20% of the deaths did not have an operation as part of their surgical episode, and also in those did we show that the clinical management issues decreased with time as the audit process continued. And if we look at the first surgeon, first line and second line assessors, all of these diminished when assessed by all of these three categories of surgeon. If we look at the frequency of issues identified by the assessors, and this is in order of frequency, operation inappropriate is where the operation was deemed either incorrectly performed or should not have been performed at all, top the list, followed by delays in treatment, preoperative care issues, management or protocol issues, and postoperative care issues. Now, if we look at this over time, we can see that all of these decreased, specifically delay in definitive treatment and operation inappropriate. So I think, although we're not saying this is cause and effect, it's certainly a very clear trend. Now, we have a tool available to us which is independently collected, which is the Victorian admission episode data set. And this is very accurately submitted by every hospital, private and public, and centralised. And if we look at the mortality over the same time periods as the audit's been in operation, we can see there's a significant decrease in the reported state mortality data from all patients having surgical operations. Now, we also get feedback from fellows. We ask for this, and this is in view of the title of the talk, Audit Impacts Practice. I think there's general perception that this is a good exercise. I've left out all the bad reports intentionally. So the key points for VASM is that it has improved practice, both according to feedback from fellows and the outcomes presented. There's been a decrease in surgical mortality over time. We're not saying that's cause and effect, but it's an observation. We've found that assessors identify more clinical issues than the treating surgeon, which is useful to know. There's been a decrease in clinical management issues by surgeon and assessors, and there's a specific decrease in the issues of delay in treatment and inappropriate operation, and there's been a trend for increase in critical care utilisation. Now, my other hat is that I administer the Australasian Vascular Audit, and Stephen was interested in disseminating how we handle outliers. So I'll just go through this very quickly. It's a compulsory vascular audit. It's been in operation since 2010 across Australia and New Zealand. The same privacy and absolute confidentiality exists as in the audits of surgical mortality, web-based data entry, and we look at the discharge outcomes of 4 index operations. And these are mortality after open and endovascular aortic surgery, stroke and death after carotid interventions, graft occlusion and amputation rate after lower limb bypass, and occlusion rate after hemodialysis access creation. We do risk-adjusted analysis using logistic regression analysis, and we display them in the very popular funnel plots, and this shows a clear outlier for open aortic surgery mortality for last year, for 2012. And this, we also amalgamate the data, so we did 3-year risk-adjusted funnel plot analysis for occlusion following infrainguinal bypass, and there was one clear outlier above the 99th upper confidence interval. So what do we do about these statistical outliers? We do not do anything based on a statistical outlier. We subject them to our algorithm, which is, as you see here, there's an audit monitoring committee of 3 elected members. And once the statistical outlier has been identified, we notify the member, who then checks all the data that's been analysed for accuracy, because that's the first thing, is the data accurate? The surgeon can request assistance by another member of the society. If the review by the Audit Monitoring Committee, which is obviously experienced clinical detailed assessment of the patients, each patient. Then we just continue audit and follow up. If the review demonstrates unsatisfactory results, we notify the president of the society, and the surgeon is notified and advised to stop performing the procedure if there is a significant problem. If the surgeon does not want to stop performing the procedure, fortunately we've never had to have this situation prevailing, then we take the appropriate next step upwards of reporting. Now, the two outliers that were demonstrated did go through this process, and I must say this shows the value of a detailed clinical assessment of problems, because they really had a most unfortunate collection of patients they had to treat with end-stage limbs that would have not been salvaged if an attempt had not been made, or the aneurysm patients were such a ill cohort that there was no clinical mismanagement of the patient, and we actually just allowed them to progress with audit. So in conclusion, both these audits have become part of the national surgical landscape. Both audits are complementary but fundamentally different. One, as I mentioned, the former is just an educational exercise. The second fulfills DMIng's complete audit loop cycle. Challenges remain for both. Accuracy and validation of data is very important. Attaining total participation remains a goal for which I shall never rest. Application of risk-adjusted outcomes and handling of outliers is, of course, very important. Thank you.